Hello everyone, this is Dr. Sanket Pisat, and in today's video we are going to be looking at various types of resectoscopes and how to choose between them. This is a very common question asked by postgraduates as well as practicing consultants where they are not able to make a decision of which resectoscope to use for which case in various types of hysteroscopic surgeries in gynecological endoscopy. So, the classification of resectoscopes needs to be understood properly if we are going to choose the proper resectoscope for our patient. And it also implies massively on the investment decision as to which resectoscope you must buy and which resectoscope you can buy as an additional feature to enhance your already existing skills and practice. So let's take a look at the various types of resectoscopes that we have. A short introduction about myself. I am a gynecological endoscopic surgeon. I practice in Mumbai, India, and I am affiliated to a variety of corporate and private hospitals across the city of Mumbai. Again, for those of you who have not yet joined, we do have a discussion group on our website endogynetraining.com. There is a link to a WhatsApp group. This is only a broadcast group where we keep broadcasting messages related to training programs in gynae endoscopy and also some real life queries of people who are facing problems while performing gynae endoscopy, where we have interactive quizzes and discussions. So for those of you who have not yet joined, I would advise you to visit our website endogynetraining.com and join the WhatsApp discussion group. So moving on to the problem today, types of resectoscopes. So let's basically first look at what are the various types of resectoscopes that are available. Generally, broadly, resectoscopes can be classified as such as two main types. So if we had to classify types of resectoscopes, the first classification that I could think of would be based on the type of current that they use. And the second classification would be based on the size of the resectoscope. Now, based on the type of current that they use, we usually have either resectoscopes that are monopolar or resectoscopes that are bipolar. There is a third variant also, which is called as pseudo bipolar. But for the sake of ease, we are not going to be going into that variant as of now. Types of resectoscopes based on current is not really the topic of discussion today because more or less we have all moved on to using bipolar resectoscopes. Still, suffice to say that if you are using a monopolar resectoscope, you must remember that a monopolar resectoscope is always to be used with the distension medium glycine. And because glycine has got a higher chance of complications like fluid overload, most hospitals and most practitioners have now moved away from using monopolar resectoscopes completely. Although there are still certain hospitals where this is used, we generally do not prefer to use a monopolar resectoscope. The bipolar resectoscope and the pseudo bipolar resectoscope are both very good in their usage. So we can use either of them. And the main advantage with both of these types of resectoscope is that we do not use glycine, we use normal saline as the distension medium. So, because normal saline is used as the distension medium, there is a lesser chance of complications like fluid overload and other patient complications which you would expect. So, suffice to say that presently we are only using bipolar or pseudo bipolar resectoscopes with normal saline. Let's now move on to the classification based on size. So let's get this out of the way and let's move on to the classification based on the size. So if you look at the classifications which we talk about based on size, we have three or four types of resectoscopes, right? So the oldest type of resectoscope based on size is what we call as the 26 French. The French is a caliber which is used for measuring most objects that are used in gynae endoscopy. We have instruments that are 5 French, 3 French. We have catheters that are 5 French, 3 French. And similarly, we have resectoscopes which are in various sizes. So the largest is 26 French. Then over time, so this was the largest and the oldest. Then over time was launched the 22 French, then the 18 French, and then we have the 15 French, which has now recently been introduced. So, how do these four resectoscope types actually compare in the real life setting? So let's see exactly how that happens, and that's what we're going to see in our next slide. So these are the types of, sorry about that. These are the types of resectoscopes that I talked about. And if you see this, this is the oldest type of resectoscope. So I'm going to label this as number one. And this is the 26 French resectoscope. This is a more broader resectoscope. And this one, the 26 French, can be either in a monopolar or a bipolar design. Since this is an older resectoscope, we have monopolar variants available as well, but you can also buy the bipolar variant. This number two, this is the 22 French resectoscope. And if you will see the tip, the size of the resectoscope is a little smaller when we go from 26 French to 22 French. Although it may not be really apparent now in this slide, we will be able to see it in the course of the presentation. The 22 French, to the best of my knowledge, is available only in the pseudo bipolar or the bipolar settings. We do not have available in India at least the 22 French in the monopolar setting. So that's the second type of resectoscope you can buy. And the third type of resectoscope, this is the 18 French resectoscope. This is available only in the pure bipolar setting and is not available in the pseudo bipolar setting. Again, if you look at the sizes, you will see that the sizes go on reducing as the number of the resectoscope or as the French of the resectoscope keeps on reducing. Now, does that really seem like much? Let's take a look in the next slide. So, we are going to go over. Now here you can appreciate the actual reduction in the size of the resectoscope. So what happens is when you look at the size, this is the 26 French resectoscope. And you can see that it is significantly larger than the 22 French resectoscope and then the 18 French resectoscope. So you can see how the sizes of the resectoscopes go on reducing as the diameter in French decreases. Also, it is worthy to note that the sizes of the loops also go on reducing as the diameter of the resectoscope goes on reducing. So with reducing diameter of the resectoscope, the reducing diameter of the loop is seen. So that is another thing which is important to know. So how does all of this really affect us? This is very important in real life practice because with the 26 French resectoscope, you find that a minimum dilatation of up to 9.5 or 10 Hagar is required. With the 22 French resectoscope, this number reduces to dilatation to up to 8 or 8.5 Hagar. And with an 18 French resectoscope, this is supposed to be an office resectoscope. That means it can be used in the office setting without anesthesia. But even if you are using with anesthesia, this either requires no dilatation, absolutely no dilatation, or at the most may require dilatation up to 5.5 or 6 Hagar. Now, while this decrease in diameter does not seem like a big thing, let me tell you that for patients of infertility, dilatation up to 9.5 is very, very difficult and may even result in an incompetent os. Dilatation up to 8 or 8.5 is much easier And the fact that one may have to dilate beyond 8.5 to 9.5 is a huge disadvantage in itself. And therefore, this makes the 22 French resectoscope significantly better than the 26 French resectoscope, at least as far as patients of infertility are concerned. When we move on from the 22 French to the 18 French resectoscope, we are talking about something which requires no dilatation at all. And therefore, this using this 18 French resectoscope minimizes the possibility of false passage, minimizes the possibility of dilatation related trauma, and makes surgery that much more easy and faster. So this is the advantage, though it may not seem like too much of difference in terms of caliber, there is a massive difference as the size of the resectoscope reduces. You can, so suffice to say that as the size of the resectoscope keeps on decreasing, the ease of performing surgery keeps on increasing. So that is the plus point in favor of smaller dimension resectoscopes. But there is a downside as well. The downside clearly is that we discussed that when the size of the resectoscope keeps on decreasing. So again, to put in perspective, this is the size for the 26 French resectoscope. This is the loop size for the 22 French resectoscope. And this is the loop size for the 18 French resectoscope. You can see that the size of the loop keeps on reducing. And because of this reducing size, the the total amount of tissue or the total volume of tissue that is going to be scraped off by the resectoscope in one sitting goes on reducing. So, for larger masses, a reduction in the size of the resectoscope loop means a longer time of surgery. So, as the resectoscope size decreases, it's easy to say, as the resectoscope size decreases, you have easier entry but more time to finish the surgery for larger pathologies. For smaller pathologies, it does not matter at all. And that is basically how the three resectoscope types figure in their usage. Also, what is different is the type of assembly of the resectoscope. So I'm going to play this video to show you how the 18 French resectoscope differs from all its previous variants. So if you look at this video now, this it consists of three parts. There is a working element. Notice that it is missing the stem which was there in all the previous resectoscope models. In order to assemble this resectoscope, the telescope is removed and the telescope is first loaded onto the working element. Note here that the working element does not have a stem which used to be there in all previous resectoscope models. The locking is similar to the previous resectoscope models, whichever brand you choose, and this now forms the stem or the proximal part of the working element. Over the resectoscope, the loop is loaded directly. So again, like I said, mentioned again, there is no particular stem, but the resectoscope loop can be loaded directly over the body of the telescope itself. Once loaded inside, it clicks in place and is now ready to use. So you can get the click sound when the resectoscope is loaded. This is the sheath of the resectoscope, the outer sheath and the inner sheath. So you can see it has an obturator over here, and beyond the after the obturator, it also has an inner ceramic sheath and an outer perforated sheath. So the inner ceramic sheath is the ceramic tip is usually guarded when the resectoscope is stored by using the obturator. So that's why during storage, the obturator has to be always kept inside and locked, and then the obturator is loaded into the outer sheath. The outer sheath has perforations. So with this assembly, one can either insert this assembly as it is into the uterine cavity, take out the obturator and then insert the working element. But where the 18 French resectoscope really scores over its previous variants is that the fully loaded resectoscope along with the hysteroscope can directly be inserted into the uterine cavity. So this entire assembly can directly be inserted into the uterine cavity without any prior dilatation. You can see the loop is completely guarded by the resectoscope. So now let's take a look at the actual video of the surgery and see how the 18 French resectoscope scores over its previous models in terms of ease of use. So this is a patient, this is a postmenopausal lady, and we are having a significant amount of trouble entering inside the uterine cavity because of cervical stenosis. Also, the other problem is that the lips of the cervix are extremely difficult to hold because most of the cervix is flushed with the vagina. Now, in this case, you can see that first I'm trying to go inside with a diagnostic or an operative sheath, but I am finding it pretty difficult to go inside because of the stenosis. Having said that, we will first try to do a dilatation of the cervix using a hysteroscopic scissors. We understand that trying to put in a hysteroscope uh, after attempting a dilatation at this stage is really not going to be a good idea because the dilator may end up into a false passage. So the way forward over here is to dilate the cervix under vision using the hysteroscopic scissors. This has to be a slow process because if this dilatation is done wrongly and the starting angle of inclination of the hysteroscope is wrong of the scissors, then what can happen is one can easily perforate the uterine cavity, particularly in a small postmenopausal uterus. Once these short bursts of tunneling have been done and we are convinced about the nature of the canal and where the canal actually is, one can follow the principles of hysteroscopy to align the notch with the opening on the cervix, and then one is able to enter the uterine cavity because the distension slowly distends the internal os and allows the entry of the hysteroscope inside. So you see here I have created an adequate opening and I feel now with adequate amount of pressure, I should be able to enter inside the uterine cavity without any problem. So here without using a dilator, I am now able to enter inside the uterine cavity and visualize the polyp which is growing inside. Again, with a dilator, it may not be possible to even reach inside the uterine cavity because the possibility of creating a false passage in such a case is very, very high. Once inside, we enlarge the opening a little bit of the internal os to make subsequent attempts at entry into the uterine cavity easier with the resectoscope. I'm not trying to remove this polyp with a scissor because again, I'm going to have issues with specimen removal. Once this is done, I assemble the resectoscope and notice that even with the resectoscope, I have not used any prior dilatation. This is the 18 French resectoscope going inside directly without any cervical dilatation. The advantage is if again I have to dilate the cervix for the sake of putting the resectoscope inside, there is again a possibility that I will create a false passage and the whole surgery will become very messy. So you can see that the resectoscope is inside now. And once it is inside, the resectoscope is as effective as any other diameter of resectoscope. So the main advantage of this resectoscope being able to enter inside the uterine cavity without any prior dilatation. Also notice that because the loop size is small, I'm having to make multiple attempts to remove the same pathology, which I would have otherwise been able to remove maybe at one go using a 22 French or a 26 French resectoscope. So here you can see almost the entire resection of the polyp is complete. You can shave the walls equally well. Again, performing something like a TCRE with this loop will be a very bad idea because you have a lot of surface area to cover. So that's for this case, and you can see that the pathology is almost out entirely. Only thing is I'm going to have to do the shaving in smaller bits. Let us compare this now with yet another case and what happens when the size of the pathology to be removed is significantly larger. So when the size of the pathology is larger, what we have to understand is that we are dealing with the volume of the pathology. For example, here we have got a large submucous myoma that is approximately 1.5 or 2 centimeters in diameter. Because of the large size of the loop, and this is an unedited video, you can see the speed at which I will be able to resect this pathology. Because of the larger size of the loop, once I have tested the loop, I can use the entire depth and entire circumference of the loop to quickly shave off the pathology without stopping in between. The larger the loop, the more is the bits of the specimen that are going to be created at one single point of time. So you can see that in hardly 10 or 15 shaves, I am able to deal with the majority of the fibroid and I don't have to go back and forth. This, of course, comes with the slight disadvantage of having to dilate the cervix. But then, with that, I get the advantage of being able to perform a faster surgery with less chance of fluid overload and a quick in, quick out procedure. So, that is how we are able to remove most of the fibroid. And here you can see I am at the base of the fibroid, and entirely the fibroid polyps or the fibroid chips of the fibroid have entirely been removed. So, in order to summarize, one can choose whichever type of resectoscope you prefer, but remember that as the size of the resectoscope decreases, the ease of entry will be more, but the possibility of doing a larger pathology becomes more and more difficult. Hence, if one has to buy or if I have to make a purchase decision, the resectoscope that I would buy definitely will be the 22 French resectoscope, and this is compatible with a 2.9 mm telescope. For larger pathologies, one may additionally buy a 26 French resectoscope if required, and this will be compatible with a 4 telescope. But I would also suggest to purchase, if you have a more amount of infertility related work and if you want a more smooth experience, an 18 French resectoscope. This also works with a 2.9 telescope. So I hope this has been helpful. My choice of resectoscope for all cases will be a 22 French if it is one single purchase that you are making. But the 18 French and the 26 French still have their place for different types of surgeries. And if you are someone who's performing regular resection and regular hysteroscopic surgery, it actually makes sense to have all three designs of hysteroscope in your armamentarium so that you can offer the patient a safe and effective surgery. If this has been helpful, I would request you to follow us on by visiting the website www.endogynetraining.com and do click the icon above to subscribe to our channel and to stay connected for more such updates. Thank you so much for your patience and for listening.